All right, so today is over chapter 37, 38, and 39. We are going to talk about start out with assisting over the physical exam. A physical exam is what you think about when you go into a doctor's office and get just like a normal checkup, or if a patient is sick, then they're going to possibly get a physical exam from a nurse or doctor. The only thing is why we teach you about this is because you may need to assist the nurse or doctor in doing this. So the exams themselves are used to promote health, to determine fitness for work, and to diagnose disease. Your role as a CNA is to know the agency policies and procedures and what the examiner prefers. So when you first get started, even at a new job, you're not going to know what the examiner prefers. So hopefully somebody tells you that, or the person themselves kind of coaches you through it. So some of the instruments used in an exam, you guys are very familiar with most of these, is a laryngeal mirror, which is used to examine the mouth, teeth, and throat. Most commonly, I see that being used in a dental office more than necessarily us doing that. A nasal speculum is used to examine the inside of the nose. An ophthalmoscope is used to look within the eye structures. An otoscope to look in the external ear and the eardrum. A percussion hammer is what we used last year to check reflexes, so it's used to tap on body parts to test reflexes. A tuning fork is vibrated to test hearing, and a vaginal speculum is going to open the vagina to examine and the cervix. So this is going to be a picture. It's not showing up. All I can see is white on them. A picture of all of these tools, so the ophthalmoscope, percussion hammer, vaginal speculum, nasal speculum, laryngeal mirror, otoscope, and tuning fork. Some of these should for sure look familiar to you guys. So in preparing the patient for the actual physical exam, you should respect their personal feelings and concerns. They need to be prepared physically and mentally for the exam. So the nurse is going to explain the procedure and the purpose and what to expect, and then the patient must give their consent to have the exam even done. You're going to assist the nurse by making sure that the patient is provided with privacy. You can screen the person and close the room door, help the person put on a patient gown, explain that the only part being examined is the only part being exposed, and have the person make sure that they void or urinate before putting on that gown, even before coming in the room. It is very hard to feel like proper organ structure if you have a really full bladder. I'm going to actually move structures in like a different area within your abdominal cavity. Also, it could cause the patient a little bit of pain if you're sitting there digging on their bladder and they have a full bladder that they just didn't realize yet. Also, you could prepare the patient by measuring their weight, height, and vital signs. You're going to record those measurements on the exam form. You could also be in charge of draping the person. So draping it means that you're putting a paper drape, a bath blanket, or sheet or draw sheet on them. And then lastly, you're going to put them in the correct position for the exam. If the examiner wants you to do that, then that's fine. A lot of times they'll have you go ahead and wait to put them in position, and they will once they enter the room. The examiner is the one who tells you how to position the patient. Before helping the patient assume and maintain the position, explain why the position is needed, how to assume the position, how the body is going to be draped for warmth and privacy, and then lastly, how long to expect to stay in this position. So the first position is the dorsal recumbent position. This is going to be where the patient is basically laying flat on their back or supine. They do have their legs together, but their legs are typically, their knees are flexed and hips are externally rotated, okay, if they're examining the perineal area. You should drape the patient as much as possible. Hopefully you have a blanket that's rectangular in shape, and you can drape them completely. The lithotomy position, this is used to examine the vagina and cervix. The hips are at the edge of the exam table, the knees are flexed, and the hips are externally rotated. The feet are in stirrups. There needs to be a drape, as there is for perineal care as well. So the drape is put on normally here. The next two positions, we're going to put on the drape a little bit differently. So this is the knee to chest position. This is going to be used to examine the rectum as well as the next position. The patient here kneels and rests the body of the knees and the chest. The head is turned to one side. Arms are above the head or flexed at the elbows. The back is straight. The body is flexed at about 90 degrees at the hips. You need to apply the drape in a diamond shape. Okay, so you're providing them the most privacy as possible and uncovering them as little as possible just in that area that you're going to examine so that they feel more comfortable. So this one is called the Sims position. It is sometimes used to examine the rectum or vagina. They are basically laying sideline with one of their legs up or the top leg up. You also should drape in a diamond shape, and the examiner folds back the near corner to expose the area being examined. You may be asked to prepare, position, or drape the patient, assist the doctor or nurse during the exam. Then after the exam, you may be asked to assist the person to dress or to return to bed, discard disposable items, replace supplies, and clean reusable items or send them to the storage area for sterilization. For example, sending a reusable speculum to the supply department for sterilization. I've never seen a non-reusable speculum. Most of them are metal, and they're used one time and then sent to sterilization. All those microbes are killed and then put back in a sterile package. You need to also possibly cover the exam table with a clean draw sheet or paper. Any specimens that have been collected, make sure that they are labeled properly. And then also have a requisition slip, which is the order for the lab. You should clean and straighten the person's unit or exam room and follow any agency policy for soiled linens. Most of the time there's going to be one of those linen carts like we have in the lab in there, and you just put soiled linens right in there. So the question here is, during an exam, you must leave the room several times for supplies. What problems does this cause? How could this have been prevented? It does. You're right, it invades their privacy. What else would it do? Like, so if you're invading their privacy, how are you probably making them feel? Possibly a lot of different ways, but what are some? Embarrassed, good. Uncomfortable. Probably a little bit like we're increasing their anxiety as well with the whole process. So, if we can get our supplies all together at the beginning, then that's going to be the ticket to not having to go in and out the door and making them more anxious as well. All right, so making sure that we have all of our supplies before we do it. All right, we're going to move on to chapter 38. This is the one with 4 videos. It's about collecting specimens. So we're going to talk about collecting urine, blood sugar, stool, and sputum. Okay? So collecting and testing specimens. So specimens are ordered by doctors. Specimens or samples are collected and tested to prevent and detect and treat disease. Most specimens are tested in the lab. All specimens are sent to the laboratory, though require requisition slips. Requisition slips just mean that there's an order for the test, okay? But there are also some tests that are done at the bedside. And if it's a test at the bedside, then that means you as a CNA can do it. Starting off here with urine specimens. So urine specimens are collected for urine tests. A random UA or urinalysis is going to be used for routine. It is collected anytime in a 24-hour period. Many people can collect the specimen themselves, but the weak and very ill patients may need some help. So how we can do one very easily is we can put a clean, very clean, brand new, what we call hat in the toilet. And so this white thing that I know you guys measured stuff with last year, those are called hats, because if you flipped it over, it kind of looks like a hat, okay? So you can see that there's measuring lines in there, and that's what we looked at last year, but these are more collection devices than anything for like if we have to grab a specimen. So it would be very easily that you could pour this into a specimen container, of course with gloved hands, label it, and then you have your urine specimen. Would this be sterile or unsterile? Unsterile. It would not be sterile. You pretty much, to get a sterile specimen, you have to do a little bit more cleaning, of course, and we're going to be coming up on that. But also, to get the most sterile specimen from the bladder would actually be to cath the patient. Okay. So a midstream specimen. These are a little bit harder to do for the patient and for the worker if they have to help them. So this is called a clean catch specimen or a clean voided specimen. The perineal area is going to be cleaned before the collection of the specimen. They usually provide about 3 wipes. They have you wipe 3 separate times with 3 separate wipes, throwing them in the trash after each time. And so the area is cleaned beforehand, and to collect the specimen, the patient starts to go, stops midstream, then you put the container under to collect, and then they collect it. So if it's an elderly patient or even a patient that has never done this before, you can imagine how hard this would be. And this is like an absolute no-go for children. You cannot stop them midstream. Okay, it's like, okay, you're gonna have to stop. Does that make sense? It's hard enough for adults and elderly. So you're gonna stop the urine midstream. The sterile specimen container is then positioned, and then the person voids into the container. So these are probably gonna be one of the hardest to obtain, but it can be done. Next up is the 24-hour specimen, and I do have a video over this. This is one of the 4 videos. This is all urine voided for a 24-hour period. Like the renal doctors, the urologists, they kind of look at these and so forth. The urine is going to be chilled on ice or refrigerated during this time. They don't want it to be just sitting in a room, kept warm. So a preservative is also added to the collection container for some of the tests as well. The picture over here on our left is going to be them actually drawing urine from a catheter, which is nice, and if you need to do that, then that's fine, but this orange container over here, this is going to be one of those 24-hour collection things. So you could actually collect the urine still in like one of those hats, that white hat, and then just every time you dump it in this. So typically, pretty typical scenario in a hospital or nursing homes, they get one of those pink buckets like we did the rinse water in, fill it full of ice, and then put this container and keep the ice fresh quite a bit, putting this container back down into the ice every time after we're putting new urine in it. So it's not that we're having to keep it like frozen cold or anything like that. It's just cool to the temperature until the 24-hour collection is done. If you miss one void during that time, they want you to start the whole 24-hour process over again. So if the patient doesn't collect one time, something like that, then they want you to start the whole 24-hour process over again. Okay? Kind of weird, but I know they like to order this. So the person voids at the beginning of the 24-hour specimen to an empty bladder. You're going to discard that first voiding and then save all voidings for the next 24 hours. If the test needs to be restarted if a voiding was not saved, if there's toilet tissue was discarded into the specimen container by accident even, or if the specimen contains stool. To collect urine specimen from an infant or child, we're going to use these collection bags. They are called wee bags. They're just kind of like a sticky substance, like right on here, kind of like tape basically. And then you put those over the patient. They're not perfect. Okay, a lot of times the urine ends up going on down and not even in there, but then sometimes they do work. If we can't get a specimen by that, then typically we will do just like a really super small feeding tube to act as a catheter, just in and out procedure, not like left in. Okay, to get the urine specimen from a child. Voiding on request is hard for a toilet-trained toddler and young children. Sometimes potty chairs and specimen pans are useful for them. And remember to use terms that the child understands. The doctor is going to order the type and frequency of urine tests. The nurse may ask you to do these simple urine tests. One of the tests that we can do as CNAs is going to be testing for pH, testing for glucose and ketones, and testing for blood. All these things, we're going to use these things called reagent strips. And so basically, like this picture down here, this is an example of the pH strips. So then we just compare it to the color and then we document what we find, okay? And so testing for the pH, your urine pH, you're looking to see if it's acidic or alkaline, or if it has glucose or ketones in it. And then the diabetic patients, if your urine has a lot of sugar or ketones in it, then that's not healthy for them, okay? So it's usually done for glucose patients about 30 minutes before each meal. And then that's how they're going to change their medications like their insulin or even possibly their diet decisions. So testing for blood, we can do that in urine as well as a CNA. With those reagent strips that they have for that. So injury and disease can cause hematuria or blood in the urine. Sometimes blood is seen in the urine, but sometimes it's not. So if it's hidden or not seen, whether it's in stool or urine, it is called occult. And a random urine specimen is going to be needed for that. Using the strips, do not touch the test area on the strip. Of course, there's the other part that you can touch, but don't ever touch the test area where you're going to be putting the sample on. Dip the strip into the urine and compare the strip with the color chart on the bottle. Straining urine. So we're mainly going to be straining urine for patients that have kidney stones. That's really the only thing I can ever think of. So anytime a patient walks in with a kidney stone or into a clinic or any type of place, then they're automatically going to give them this really fine strainer. Okay. So kidney stones can be very, very small, teeny, tiny, hard for us to see, or they can be larger in size as well. We want you to save all kidney stones. That's why we strain them. Otherwise, we wouldn't need to do it. And those kidney stones are going to be sent to the lab for testing. So the patient does need to try their best to strain the urine if they have a kidney problem going on. Stool specimens. Stools are going to be studied for fat, microbes, worms, blood, and other abnormal contents. Bleeding may occur in very small amounts. Stools are also tested for occult, which is hidden blood in the stool. Stools are tested for occult blood to screen for colon cancer and other digestive disorders. Occult blood tests vary, and you need to follow the manufacturer's instructions. If you look over here at picture A, that looks like a urine specimen container too, right? So they're pretty much similar. But then B over here, it actually comes, this one's really nice, it comes with a spoon. Okay, and does that really look like a spoon? No. But as far as when you are trying to scrape from a stool sample with your gloves on, we never expect you to use your gloved finger to touch stool. Okay, you should either use one of those wood clean sticks, like oh my gosh, what's it called? Like a tongue blade, okay? Like a disposable one. Or if the container comes with like a spoon like this on it, then you would use that. Okay? We never expect you to ever put your finger actually in stool and rub it on the sample. So urine must not contaminate the stool specimen. So if you're getting a stool specimen, or you need both, if you need both, you can put a hat this way and then a hat the opposite direction. But if you're just needing a stool specimen, you just flip the hat around and put it in the toilet the opposite direction as the urine. Okay? But if there's urine in it, then it is considered contaminated, and we should use another device for a bowel movement. Some tests require a warm stool, so you need to make sure and let the patient know that as soon as they have a bowel movement, you need to hit the call light and let them know so that you can take it to the lab immediately. So the second picture over here, which is this one right here, kind of starts this test here. So this is a patient with a bedpan stool. They are digging in with some kind of device there, whether it's a spoon or a piece, a tongue blade or whatever it is, and putting it in the sample container. This picture right here is a picture of this occult. Okay, so occult is hidden blood. So what they do is this kit here provides you with drops and sticks, okay, and this is a very small sample, very tiny sample. And you rub it on these two little spots right here. Then you seal the container down on this side on the front, and then you go to the back and you put drops, and it'll tell you how many drops on the back of it, and then you will get your results after a few minutes. Okay? And that's going to tell you whether you have hidden blood in the stool. This is something you guys will do as a CNA. Okay? This is a lab test you guys can do, and of course you would record the results. A sputum specimen. So mucus from the respiratory system is called sputum, especially when it's expelled from the mouth. Sputum is not saliva. Okay? Sputum specimens are studied for blood, microbes, and abnormal cells. The person has to cough up the sputum, okay, from the bronchi and the trachea. Sputum specimens, are easiest to get in the morning. Blood glucose testing, another thing that we can do, depending on the facility. Blood glucose testing or sugar testing is going to be used for patients with diabetes. The doctors use these results to regulate the person's medications and diet. Capillary blood is obtained through a skin puncture. This is what we did last year for blood typing, actually. A drop of blood is collected. You need to use the sides of the finger. I know for the blood drive they did poke the middle of the finger, but it's not like you're getting your finger stuck over and over again, and it's extremely painful if you get the middle of your finger extremely poked on. It's better on the sides. The fingertip is going to be the most common site for skin punctures. You also need to keep in mind that you need to stay away from calloused fingers. So our pointer finger is not all that ideal. If you have to, it's fine. Really, that ring finger, even the pinky, are the most ideal situations. But, I mean, if you have a diabetic patient, they're getting stuck anywhere, everywhere on their fingers because they're 3 times a day. And you don't want to go back to the same exact spot that you went before because that's going to potentially hurt them. Okay. Also, to perform the skin puncture, you should inspect the puncture site carefully for signs of trauma and skin breaks. Do not use any swollen, bruised, or cyanotic, or scarred, or callous skin if you can avoid it. Use the side toward the tip of the middle or ring finger, and use a sterile disposable lancet to puncture the skin. The person is going to feel a brief, sharp pinch. Using a reagent strip, so the same kind of strip, it's just different. It's made for blood sugar. Once again, not touching the end down here. You can always tell where the sample is going to go in. It's like yellowish or a different color than the rest of the strip. So making sure not to touch that. Apply a drop of blood to the strip. The blood glucose then level appears on the screen. And there's so many different types of glucometers available. You then document the result. If it's out of abnormal range, then you should notify the provider and the nurse as well. Do you guys remember what blood sugar should be? It's okay if you don't. It was not like a have to last year. It wasn't like a vital sign. It's 80 to 100 typically, but each facility kind of has their own guidelines with this, but it's usually 80 to 100. So what I kind of think about, honestly, with blood sugar, I think about pulse. Pulse is typically 80 to 100, and this is adult patients only on blood sugar. So I kind of like to compare the pulse and blood sugar, okay? So if you get anything out of that range, and they're letting you do it on your own after you've done it several times at clinical, that's fine. I would go ahead and report anything. I mean, you got to record anyways. Whatever your result is, you got to record it, or you didn't do it. But then I would record and then report immediately if it was out of that range of between 80 and 100. All right, so let's start the videos and skip that question here. The first thing is obtaining a specimen. This video, the voice gets a little funny, but the next three are fine.
Are you okay if you take a test
What?
Are you okay if you take a test
Yeah, that's fine.
From time to time, you will need to collect stool and urine specimens, measure urinary output, and provide other forms of assistance with elimination. These important tasks not only assist the physician in monitoring an individual's condition, but also help to maintain physical comfort and emotional well-being. In this program, we will discuss collecting a stool specimen, collecting a routine urine specimen, measuring urinary output, inserting a rectal suppository, and administering a cleansing enema. First, we will discuss collecting a stool specimen for laboratory analysis. Before collecting a stool specimen, be sure to perform hand hygiene. Assemble the supplies you will need, including a bedpan and cover, a stool specimen container and label, a wooden tongue depressor, disposable gloves, and a plastic bag. Knock and identify yourself before entering the residence room. Once inside, identify the individual and explain the procedure, speaking clearly, slowly, and directly, while maintaining face-to-face contact whenever possible. Provide privacy.
And help the resident onto the bedpan if necessary. Raise the head of the bed to help eliminate. Make sure she is comfortable and place the call signal and toilet paper with it.
I don't like this.
If she is unable to follow instructions, check out her flight specimen as soon as defecation. Write the correct information on the stool.
See how the voice changed?
I
Super
don't like
creepy.
that.
In the bathroom, ready for use. Once she is in a bowel movement,
Okay.
clean her hands and take the covered bedpan into the bathroom. In the bathroom,
It gets
use
better.
the wooden tongue depressor to transfer 1 to 2 teaspoons of fecal material from the bedpan to the labeled container. Cover the specimen container
See how,
immediately
like, it's already
and
gotten
make
better?
sure the
It's really
identifying information on the label is legible. Wrap the soiled tongue depressor in a paper towel and place it in a plastic bag. Empty and clean the bedpan, then return it to its proper place. When finished, carefully remove the gloves without contaminating yourself and place them in the plastic bag and discard the bag. If the stool specimen is not to be taken immediately to the laboratory, store it as instructed by your supervisor. Stool specimens
It's so random. The voice there, though. Alright, so this is obtaining a 24-hour urine sample.
Hello there, my name is David St. Jules and I'm going to be speaking with you today about how to do a 24-hour urine collection. So, as part of your urine collection, everyone will be provided with a urine collecting device, this jug here. Some things to note about the jug: it doesn't need to be stored in the refrigerator, it has a preservative in it, but the preservative is caustic, so it can be painful if it splashes back. So in terms of collecting the actual urine, you would collect the urine in a separate container and then transfer it to the actual jug. And so for females, we're going to be providing you with this storage container here. It sits underneath the toilet seat in the front, towards the front. And so you would collect the urine within the container and then transfer it to the jug. For males, you would be provided with a container as well. And so you would urinate within the container and then again transfer it to the jug. You wouldn't go directly within the jug because there is that preservative in the bottom, which is acidic. In terms of how to actually do a 24-hour urine collection, the way that it works is that it doesn't matter when you start the urine collection. What's important is that it is actually a 24-hour period. So if I wanted to start a urine collection now, it's 10 o'clock a.m. So what I would do is I would use the toilet, I would urinate and not collect it, and then I would record the time on the jug so that each jug has a sticker that tells you what time the collection started and ended. And then I would, all of the urine from that period on, I would collect and transfer to the jug until the following day at the same time, and then at that time I would actually urinate one more time and actually transfer that into the bottle or into the jug, and then that would be the full 24-hour period. So I'll just show you here on this device here. So you can see I've recorded the information here. So I started the collection at 10 a.m. Today, and I would collect the final sample at 10 a.m. tomorrow. And so I just initialed it there. And so that is how you do a 24-hour urine collection. Thank you.
Thank you. It's like my microwave, it says thank you when it's done. It's so weird.
Yours says thank you.
Yes, it's new.
Mine says done.
It says done. Oh, no, I think I would like that better.
Mine just beeps.
That's what my own one does. And in my other house, we don't have microwave at all. And we haven't. Because I have two weird.
Hi, today we're going to talk about how to take a sample from a blunt cannula access port. The drain bags that you're currently using have a blunt cannula access port at the end of their tubing. That's the siliconized disc right here. Taking a sample from a blunt cannula access port, you'll want two things. Your blunt cannula needle, so a plastic blunt needle, and an alcohol prep pad. The first thing that we'll do is kink the tubing right underneath, or right next to the access port. That will allow the urine to pool up underneath the access port. Once you've done that, you can go ahead and take your alcohol prep pad and wipe down the surface of the access port. Then, simply take your blunt cannula needle and puncture the siliconized disc, and then pull back to take your sample. And you're done.
Okay. Quicker than me. Was that three? I think that was three.
Oh, third one.
Hi. Hi.
Alright, here we go. This one is a pretty long one. If I can.
Hey everyone, it's Sarah with
RegisteredNurseRN.com,
RegisteredNurseRN.com, and in this video, we're going to go over how to check your blood sugar. As a nursing student, you're going to have to learn the skill of how to check a blood glucose using a glucometer. As a nurse working in the hospital setting, you will be checking your patients' glucoses, especially your diabetic patients. Now, if you're watching this video because you've been newly diagnosed as a diabetic, or you've been experiencing bouts of hypoglycemia, meaning your blood sugar drops, and you bought a glucometer just to monitor your blood sugar, this video will help you how to do that because I'm actually going to show you myself of taking a blood sugar, how to do it. And I'm going to go over all the supplies with you. Now, check out my other videos on how to do a quality control test on your glucometer, how to poke your finger with a lancet, and how to load your lancet device if you're confused on any of those things. So let's get started. This is a basic home glucometer testing kit that you can get. Now, nursing students, your glucometer in the hospital will probably look a little bit differently, but they all work the same. Now, if you were newly diagnosed with diabetes and you need some advice on getting a kit, I really recommend that for your first kit that you get a kit that comes with a meter, comes with test strips, a quality control, your lancet device, and your little lancets. Because this will help you when you're first starting out and it'll have everything you need. And they usually come with a little carry-in case, a little book log, and you can have all your extra supplies. So let's go over what's in this kit. First thing you have are your testing strips. Each monitor comes with a specific testing strip. So when you run out of testing strips, you have to buy the test strips that go along with the monitor. And please note, this is so important. Once you open up these test strips, they're only good for 4 months, okay? So write on the bottle when you open them, and they're only good for 4 months. And make sure you check the expiration date when you buy them to make sure that they aren't expired, because if you use expired test strips, you'll get the wrong readings. And your test strips look like this. This part will go into the monitor, and then this part will collect your sample, and we'll go over that here in a second. Next, we have the meter itself, so small but very handy. They've came a long way. They used to be very big. Usually you can hit the on button right here, whatever your monitor says. Always read your glucometer monitor settings because they all work a little bit differently, but this one works. You can hit this button right here or just put in the test strip and it comes on itself. We have our quality control. You'll always want to get some type of quality control testing because when you first get your monitor, you want to do a quality control test just to make sure it's calibrated right. And then you'll want to perform it, every other couple days, and especially when you change out your strips. And another thing that is important to note, this solution is only good for 3 months from the time you open it, and it expires after that. So keep that in mind. Next, what we have is a lancet device. You will need this so you can actually poke your finger. What you do is you unscrew that, you load the lancet in there, and you engage it, and then you poke your finger, and we'll go over exactly those steps on how to do that here in a second. Next, you have your lancets. These right here are 30 gauge, and I just want to show you the different gauges. You can get various gauges of lancets. You can get 27, 28, 30, 32, and 33. Basically, what it is, it's the size of the needle, and a 30 gauge is usually sufficient enough. The lower the number, the bigger the needle. So if you have really thick skin, you might want to go with a bigger gauge, but usually 30 is sufficient enough for people. And then this is just a little test log. A lot of monitors are fancy and they'll keep it stored in as a memory and your doctor can just upload it, but this one is just basic. And you want to record what your blood sugar is so you can keep track of it, take it to the doctor with you so they'll be able to see what your blood sugars have been reading. So now, and also some alcohol prep that you want to clean your fingers with. So now let's get ready and check our blood sugar. The very first thing you want to do before you check your blood sugar is wash your hands with warm water because that's going to increase the blood flow to your fingertips. Because when you check your blood sugar, the best place generally is to check on the fingertips. Some devices say you can use your forearm, your palm, but this device specifically recommends fingertips. So after you wash your hands, you're going to get your supplies, and what I like to do is get everything set up. So very first thing, it doesn't really matter what order you do it in, just as long as you do it, we are going to prime our lancet device. So in order to do that, the lancet devices look a little bit differently, but they work the same. They generally twist off right here. And you're going to take the cap off, and this is where your lancet is going to go. Your lancet typically has these little grooves around it, and it will fit snugly inside this part. Now I just want to show you something. Whenever you push this part in, notice it engages the needle. Now, whenever you're ready to poke your finger, you're going to hit this button. And when you hit this button, like that, it takes the needle and pokes it in your finger. So what we want to do is just get that lancet inside the device and line it up with these grooves and just push it in snugly. And we're going to go ahead and engage that. And now we need to expose the needle. The needle's been protected by this little area right here. So what you do is just simply twist it off. And if you can see right there, it's exposing your needle. Now we're going to put the cap back on. And we're going to just twist this on right here. And we are almost ready to go, but if you notice, can you see these little numbers right here on the device? This is how deep the needle is going to go into your finger to draw blood. So here's generally the rule. You'll want to read the instructions on your lancet device, but typically you want to use a 1 to 2 setting if you have really thin skin, a 3 to 4 setting if you have just average skin, and a 5 or 6 setting if you have thick callous skin. So what I like to say is 1 to 2, if you know, women, we tend to have thin skin. If you're on corticosteroids or your hands bruise easily, probably 1 to 2 is sufficient enough. 3 to 4, typically young people have a lot of collagen in their skin. It's average thickness. 3 to 4 is good. But if you're a man who works a lot with your hands, even women, and you have calloused hands, a 5 or 6 is definitely where you want to go because you want to be able to draw enough blood in one stick. So here I am just going to slide mine to a 3 because that's sufficient enough on me. Okay, so we have our lancet device ready, and we can't hit this button yet because remember the needle will go off. So we're just going to set that aside. Now we're going to get out our test strips. And remember, these were good for how long? 4 months.
4 months.
And what we're going to do, I'm going to let you look at the test strip.
Cut her off
Always
here.
read.
So it is very important that you know the 4 months thing because it should be written on the bottle when it was opened. Okay? So let's move on here to the next chapter, get done with CNA lecture, and then we will go to break. So we'll be just a few more minutes. This next one is a long PowerPoint, but there are no videos. So the next, chapter 39 here is about the patient having surgery. So we're going to look at the before surgery, the during surgery, and then after surgery. And then just kind of looking at the general consensus about it. Surgery is done to remove a disease or injured body part. It is there to remove a tumor, to repair or an injured body part, to make a diagnosis, to improve appearance, to relieve symptoms, and to restore and improve function. And then lastly, it could also be to replace a body part. Surgery often requires a hospital stay, but they are trying to decrease that every single day, okay? If a patient is having inpatient surgery, then that means that they're typically admitted the morning of the surgery, or even maybe 1 to 2 days before, trying to get ready for it. Same-day surgery is going to be where it's an outpatient center or same ambulatory surgery clinic. The person goes home the same day of the surgery. Some patients go correctly to surgery also from the emergency department because they've had some kind of trauma. Same-day surgery is going to be the most common, especially nowadays. Such surgeries are done in hospitals or surgery centers. They're designed and equipped for certain surgeries on that day, and they're completely prepped for them. Surgeries are going to be elective, urgent, or emergency. Elective surgery is done by a choice to improve the person's life or well-being. This surgery is typically scheduled in advance. An urgent surgery is going to be more like a heart surgery, a cancer surgery, or something like that. It's done to prevent any further damage to the tissues or so forth, but it's still not emergent. An emergency surgery is going to be done at once immediately. Typically, we don't even have time to get consent. So think about those stabbings, gunshot wounds that come into the ER and so forth. So vehicle crashes, any of that stuff is going to be an emergency surgery. The person or patient is going to be prepared for what happens before, during, and after surgery. Pre-operative means before surgery, where post-operative means after the surgery. Some people recover from surgery in nursing centers and rehabilitation centers as well because they just can't quite get home after their surgery, and some still need home care. Surgery can cause a lot of fears and concerns, and mental well-being affect that as well. Also, past experiences can affect feelings of them. Some people don't, though, also share their fears and concerns, but sometimes you can see it on their vital signs before surgery. Mental preparation is going to be important, and respect the patient's concerns and fears. The doctor should explain the need for surgery to the patient and family. They should be told about the surgery procedure, the risks, the benefits, and the possible complications. They should also be told about the risk from not having the surgery done. They should tell them who's going to do the surgery, the date and time of the surgery, and how long the surgery will take. Any questions should be answered from the doctor. Any misunderstanding should be cleared up. Any care instructions should be given to the patient as well from the doctor. After surgery, the doctor decides what and when to tell the patient and the family about the results. It is not our job as a CNA or a nurse to tell the family the results. So it is not within our scope of practice. The doctors have to tell them any surgery results. Even if we know something bad, like cancer or something like that, then we have to wait for the doctor to tell the patient. Your role as a CNA, you should listen to the patient, refer any questions to the nurse, explain the care you will give and why it is needed. Follow any communication rules, and those main communication rules are going to be about what I was just telling you. You know, that you and I as a CNA and nurse, we can't tell the patient any results, but that we can empathize with the patient. We can get the doctor in there to answer any concerns and so forth as well as we can. We can use verbal and nonverbal communication. We can provide care with skill and ease, report any signs of fear and anxiety, and report a request to see a member of clergy as well. The goal preoperatively is going to be to prevent any complications before, during, and after the surgery. We have to do a lot of pre-op teaching, meaning explaining the tests and their purpose, doing any skin prep, so we may have to shave, we may have to clean with certain microbial cleaners, and do personal care as well. So it just kind of depends. And then the nurse is going to explain what to expect before, during, and after surgery. Preoperatively, we may even do deep breathing, coughing, and incentive spirometry. Incentive spirometry is that clear thing that's in the patient's room or after surgery where they breathe. They give a deep breath in and a deep breath out, and then they're trying to hit that certain goal. That prevents pneumonia, fever, and really helps kind of open up those lung volumes. Leg exercises can be done as well. Talk to about the PACU, or that the PACU is going to be the area where they go to recover after surgery. Vital signs are taken often, especially until they're stable. Foods and fluids, what they can do before and after with foods and fluids. Turning and repositioning. We can do early ambulation as long as it's still okay. But we do like to have them walk as soon as we can, as long as it's safe, after surgery as well. We should talk to them about the type and amount of pain to expect, and the treatments and equipment, and any position restrictions. Before surgery, tests are common: chest x-rays, complete blood counts, urinalysis, electrocardiogram, and other tests depending on the condition or surgery. And there's a lot of like MRIs that have to be done before surgeries. If they need to go in and see where they're going, okay? So typically that has to be done. As far as nutrition and fluids, the patient is NPO for 6 to 8 hours before the surgery. What does NPO mean?
Nothing by mouth.
Thank you. Nothing by mouth. So if this does not happen and the patient lies about or something like that, they're very much at risk for aspiration and dying during surgery, and very quickly. After the anesthesia, sometimes the surgery hasn't even started. If the patient lies about that they had a sip of coffee or something like that, depending on how much that sip of coffee was, it really could harm the patient. It could come back up as soon as they put them under anesthesia and potentially kill the patient, because then it goes down into their lungs, okay? And then we don't really ever know it, actually, even until the patient's like all of a sudden coding. So I will tell you that this happened to my step-grandfather when I was a junior in high school, and we were sorting FFA fruit. But he went in for an emergency appendectomy, and they recorded what time he had last ate because it was an emergency, but they didn't wait long enough, and he ended up aspirating and dying within anesthesia, with just anesthesia, and hadn't even got to do the appendectomy yet. So it's very, very real. Please report the correct thing. An NPO sign needs to be placed in the patient's room. A water pitcher and glasses need to be removed if the patient is NPO. It's not worth risking the surgery or their life or anything like that. They just need to kind of maybe move the surgery till later in the day, where they're 6 to 8 hours NPO or something like that. Bowel elimination. So bowel surgeries may require cleansing of the bowel and feces, like those colonoscopies, any other bowel surgeries, then they're going to have to do what's something called a bowel prep and get that all cleaned out. Bowel prep usually includes enemas or some kind of laxatives for several days before in a certain diet. But then sometimes these enemas even have to be given afterwards to prevent constipation after surgery. Urinary elimination, you should have the patient void before even starting their IV, kind of before doing a whole lot of things. For sure, before you give any drugs or pre-surgery medications, you need to have them empty their bladder. Personal care before surgery is going to involve a complete bed bath, shower, or tub bath, removing any makeup, nail polish, or fake nails. Our pulse oximeters, they don't read through fingernail polish, okay? And that's how we're going to be measuring your oxygen during the surgery. And so we have little nail polish remover wipes. They look just like alcohol wipes, okay? But they say nail polish remover on them. We have to clean off quite a few fingers if the patient has nail polish on so that we can have multiple sites for oxygen pulse oximetry during surgery. Also, we can check cap refill during surgery as well and make sure that everything is going okay that way. Make sure to remove all the patient's hairpins, clips, combs, wigs, hair pieces, and other items. Surgical caps are going to be worn to keep hair out of the face and the operative site. Oral hygiene for comfort. Remove and store any dentures in a denture container and make sure and label that and take care of that. Remove any prosthesis before surgery. Often elastic stockings are going to be put on before they're transported to the OR. Elastic stockings, we call them TED hose, and that's one of your guys' CNA skill checkoffs that we'll be doing on a mannequin. All jewelry also needs to be removed and stored for safekeeping. We do a pre-op call the day before. Typically, we tell patients, please don't wear any jewelry, because then we have to store it for you once it gets here, which is okay, but we don't want to risk losing it as well. Also, you have to do any skin prep. So you may have to do, this bottom picture down here is doing like a chlor prep scrub with a certain cleaner that's very, very antimicrobial and helping prep the skin. You also need to potentially shave the area. If you have a surgical site and there's any hair at all, they're going to want it shaved completely and prepped in that area. So clip the hair, remove the hair at and around the site is going to be a very typical pre-op nurse thing. So these are the areas of the body that have to be prepared, completely prepared, clean, bathed, shaved, everything for these specific surgeries. So look over there, abdominal surgeries, open heart. Look at open heart, how much needs to be done down to the arms to here, legs, because open heart surgery, they're going to be going in these big veins down here as well as accessing and cutting down big veins in here too, because they're not only doing open heart surgery, but they're having to access these other points to basically keep you alive, to keep the blood flow going, and they use big old pumps and so forth for those surgeries. So that's why so much of your body is prepped there. Cervical spine procedures, chest, breast, and upper arm procedures. These are going to be the skin areas that are prepped in the pink. Surgery consent. A person's consent has to be obtained by a doctor before surgery. There is very, very few circumstances where a registered nurse can get it, but it most of the time needs to be a doctor that gets the consent. A parent or legal representative has to sign for a minor child, or if a patient is not mentally competent, then their legal representative should be there to sign for them. The doctor is responsible for securing that. They're making sure it's the right patient, right time, right location, several different things, and answering any questions. They're also discussing those risk factors and risk of not having the surgery as well during that time. The pre-operative checklist, this is on a computer, but there's a pre-op checklist once it is completed, so it's going to contain like vital signs, whether you've cleaned the patient, gotten them completely ready, IVs, so forth. Once it's completed, you need to let your staff know that the patient is ready for surgery. The pre-op checklist has been completed. The doctor marks the surgical site also with a marker, a skin marker, before. This is to prevent the wrong body part or area being operated on. So if somebody was wrongly operated on, and that's what started that practice, I will tell you. Pre-operative drugs are given before the patient is transported to the OR to kind of decrease their fear, anxiety, and to help them relax and start to feel drowsy. This also reduces respiratory secretions and to prevent aspiration as well as those. These medications also have some nausea and vomiting, decrease medicine in them as well, which helps with surgery. As far as transporting the patient to the OR, bed rails should be raised and the patient is not allowed out of bed. Once the patient is transported to the OR, they are done that by the OR staff comes over and gets them from the pre-op area. Identification checks are made and the person's chart is given to the OR staff member. Sedation or anesthesia. Sedation is the state of quiet, calmness, or sleep produced by a drug. There are 3 levels of sedation, include minimal, moderate, and deep. General anesthesia is going to be the loss of consciousness and the feeling and sensation, and a drug is given IV in this circumstance, or a gas is inhaled. Regional anesthesia is more just a regional area, so maybe like a whole arm, a region. We know with our body directional terms, like a region or area. The person is typically awake with regional anesthesia, and a drug is injected into the body part. But when we think about like having a cavity worked on or a very small area worked on, then we're going to look at local anesthesia. So it's the loss or feeling of sensation in a very small area, and the drug is injected right at the site. Sedation and anesthesia are given by specifically trained doctors and nurses. So those doctors are called anesthesiologists. The nurses are called CRNAs, and certified registered nurse anesthesiologists. They make bank. I'll just tell you guys that. They make like anywhere from like 125 to probably more, looking at all the way up to 200 now a year. So you become a registered nurse first, and then you get 2 years of either ICU or ER experience, and then you get accepted into a CRNA program, and you have your CRNA within like a year, year and a half. So pretty cool program. Post-operative care, so this is going to be the after surgery, the person is taken to the PACU. The doctor allows the person to be transported to their regular room from the PACU. When their vital signs are stable, the respiratory function is good, they can breathe good, and the person can respond and call for help. The room must be ready for the patient. After the person is transported into the OR, the room can go ahead and be prepped for them to come back, so making the bed, placing equipment and supplies in the room, and moving furniture out of the way for the stretcher to come in and get the patient. So forth. The PACU staff calls the nursing unit when the person is ready for transfer. The transfer has to be done by the PACU nurses. The person is transferred from the stretcher to the bed. You can assist and help position the patient at this time as a CNA. Vital signs then are going to be measured by you, and observations are going to be made. The nurse checks the incision for bleeding, and vital signs are done pretty frequently, like every 15 minutes. A catheter, IV, and other tube placements and functions are checked as well. Bed rails are raised. The signal light is placed, or the call light is placed within the person's reach, and necessary care and treatments are given. Then the family can be with the person if they're back to their regular room. Your role in post-operative care kind of depends on the person's condition. Most commonly, you're going to measure vital signs, pulse oximetry, and then the person's condition, if they're awake, alert, sleeping, whatever they're doing. We do start off with vital signs every 15 minutes until they stabilize. After that, every 30 minutes for 1 to 2 hours, every 4 hours, every hour for 4 hours, then every 4 hours. So it's pretty frequent for a while after surgery, just making sure that they're okay. The nurse is going to tell you how often to check on the patient, okay? Positioning, the person is usually positioned for easy and comfortable breathing to prevent stress on the incision. So if they have a big old fat abdominal wound, we're more than likely not going to put them flat on their back, because that is stretching them out. You actually want to keep, if they have an abdominal incision, you actually want to keep them like this. Does that make sense? Because then you're not stretching on those abdominal muscles. Turning could be painful, but they do need to still be repositioned every 1 to 2 hours. Provide support, use smooth, gentle motions with this. Post-operative care, you're going to prevent any respiratory or circulatory problems. Have them practice with that incentive spirometry and cough and deep breathing exercises. And then also those things at the foot of the bed, sometimes those are called SCDs that we're hearing talked about with, that will help prevent any circulation problems. Circulation must be stimulated for blood flow in the legs. The blood flow is sluggish, and the blood clots may form if the patient is just laying there like they are quite a bit after surgery. So we want to prevent an embolus from happening, or blood clot. Things that we can do to make that happen are going to be leg exercises, ambulation as soon as possible, so walking as soon as possible, elastic stockings that are frequently called TED hose, and that's one of our things. So these pictures here are going to be examples of range of motion or leg exercises here. Also elastic bandages, and then those devices that pump up, they are attached to a pump with a clear tube, and it fills up and down with air, kind of moving that, circulating that blood around in your lower legs. You need to also look at wound healing. The incision needs protection. Healing is promoted, infection prevented. Sterile dressing changes are done by the doctor or nurse. Your agency may let you do simple dressing changes as a CNA. The person returns from... What is happening over there? Are we good? Oh, okay. They're doing sketch. I thought maybe a fight's going on. I just never know. Okay. So the patient's gonna return from the OR with an IV fluid, you don't just immediately give them a cheeseburger when they get back from the OR, okay? You actually gotta start them on clear fluids, then a little bit thicker fluids like a soup or something like that, and then you move them onto a regular diet after that. But they just need to start out with like water, clear juices, things like that, to start off with. You wanna start them out easier, otherwise they're gonna get really sick on you. Elimination, you wanna make sure that you measure any intake and output, and report the time and amount of the first voiding. A lot of patients, we have to have them urinate or have a bowel movement before they leave, before they can go home. Comfort and rest. The degree of pain after surgery depends on the extent of surgery, the incision site and size. If drainage tubes, cast, or devices are present, positioned during surgery. Pain is going to be common after surgery, and we want to make sure that we do any pain relief measures. This is a picture of the TED hose I was talking about that we will apply. Make sure that for pain relief that you follow doctor's orders for drugs, and the nurses need to use the nursing process to promote comfort and rest. Personal hygiene is going to be important for physical and mental well-being. All right, I'm not going to make you guys answer this question, and I'm going to end it here. So we will go ahead and go to a short break, and then how long are you guys wanting for committee?